The new ESC guidelines on atrial fibrillation carry a large number of important messages for practice. They were presented in Stockholm by the chair of their task force, John Camm.
We have introduced a scoring system for symptoms in atrial fibrillation, which is called the AVERROES score.
Two other new scores are introduced in these guidelines. The CHADS-VASc score, to measure individual vulnerability to thromboembolic events, and the HAS-BLED score, to evaluate individual bleeding risk.
These new guidelines have important ramifications for patients. The first, I think, is that there will be a more sustained and more definitive attempt to define those patients who do not need anticoagulants and to prescribe anticoagulants to those patients who do need anticoagulation therapy. Second, we would like to de-emphasize strict rate control. It does not seem to be important since lenient rate control is very acceptable in most patients. And thirdly, we are introducing a new antiarrhythmic drug therapy which is less toxic than other therapies and offers some advantages. Finally, I think we've emphasized more the role of left atrial ablation to prevent recurrences of the arrhythmia.
In Stockholm, the ESC launched a new European survey on the practice of ablation in atrial fibrillation. This prospective, multinational observational survey will be conducted in 100 European cardiology centres, which will enrol 20 consecutive patients undergoing a first ablation procedure for atrial fibrillation. The results of the AVERROES study, presented during one of the ESC 2010 hotline sessions, clearly illustrate the big changes brought by the new direct antithrombin inhibitors.
Apixaban is an oral selective direct factor Xa inhibitor.
This large international study included 5,600 patients with high-risk atrial fibrillation who were ineligible for treatment with vitamin K antagonist. To prevent stroke, they were randomized to receive either 5 milligrams twice a day of Apixaban, a new factor Xa antagonist, or aspirin.
We showed that Apixaban was much superior to aspirin for prevention of stroke. It reduced the risk of stroke or systemic embolism by 54%. It's a massive reduction, and it was highly statistically significant. This benefit occurred without a significant increase in major bleeding compared to aspirin.
The ANTIPAF trial, the results of which were presented during an ESC 2010 hotline, was the first trial to evaluate the hypothesis that the Angiotensin II-antagonist olmesartan could suppress episodes of paroxysmal atrial fibrillation.
So the ANTIPAF trial was a prospective, randomized, truly placebo-controlled multi-center trial.
Conducted in Germany, the study included 425 patients who received, during 1 year, either 40 milligrams daily of olmesartan or a placebo.
The main results of the study are that the use of an ARB did not reduce AF burden in comparison to a true placebo-controlled group over follow-up, and also pre-specified secondary outcome parameters like quality of life, like time to occurrence of persistent atrial fibrillation or symptoms did also not change by ARB therapy. So the main conclusion is that the ARB therapy itself has no antiarrhythmic effect in this studied cohort, and that we think that ARB therapy should not be given in these patients unless indicated for other reasons.